Good evening, all. I welcome you all for the Vijaya Diagnostic Center webinar series. With this, we have a very interesting topic today, that is imaging of lung cancer, imaging of lung cancer staging. Basically, this topic is now with the modification of the lung staging system by the AJCC and International Cancer Society. This got very much importance now. So for this, we have two distinguished speakers with us. One is Dr. Arun Kanala. He's a very senior cardiothoracic surgeon and has done a fellowship in clinical thoracic surgery at Brigham and Women's Hospital, Harvard Medical School, Boston, USA. And he has done his M.Ch cardiothoracic and vascular surgery from Usmania and Master of Surgery from similar Usmania Medical College. And he is very proficient in performing lung surgeries and, of course, VATS decortications, lobectomies, bullectomies, pneumonectomies, and carcinoma lung surgeries, rib case surgeries, rib plating, thoracoplasty, pectus cases, tracheal resection and anastomosis, thymus surgeries, diaphragmatic surgeries, esophageal surgeries, and thoracic duct ligation, VATS sympathectomy, and so many surgeries. His special interest is in the non-cardiac things like chest and non-cardiac chest, that is mediastinum and lung and diaphragm and all these things. That's a very rare kind of a thing. Like many of the doctors are mostly does cardiac surgery. So Dr. Arun distinguished himself with a fellowship in lung surgery. So he's my close friend and my senior at Kakatiya Medical College. So I warmly welcome Dr. Arun for today's presentation and panel discussion.
Thank you, Dr. Krishna, for such a wonderful introduction. And is my voice audible and clear and audible?
Yes, yes.
Yeah. So thank you for the beautiful, wonderful introduction about me. Today, Dr. Krishna has asked to speak about imaging in lung cancer, which I'm going to do it today. My presentation will be very short, for about less than 8 minutes. Can I have the PowerPoint presentation, please?
Yeah. Then Arun, before that, I would like to invite Dr. Anuj Jain also to the panel. Yeah, Dr. Anuj. Dr. Anuj is a senior consultant in nuclear medicine and PET-CT at Vijaya Diagnostic Group. He is working since last 15 years with us in Vijaya, and is my close colleague, and we are neighbors basically. We share the common floor. So we regularly interact in PET-CT, and we discuss cases related to most of the cancer cases. And today it's a very interesting topic, that is that staging of the lung cancer with CT as well as with PET-CT. How PET-CT fares better in the nodal staging, that Anuj is going to tell us. Dr. Anuj is now Director of Nuclear Medicine and PET-CT at Vijaya Diagnostic Center, and he was in a brief time, he was in United Kingdom, England, and he worked in North Cumbria Integrated Care NHS Trust, Carlisle, United Kingdom, and he was consultant radiologist at Apollo Radiology International for some time, and he worked in other places also. He completed his fellow of Royal College of Radiology last few years back, and he has plenty of publications to his credit, and he's a speaker in most of the nuclear medicine and PET-CT conferences, which is being done by the nuclear medicine societies and radiology societies. And now he is a distinguished member of both the societies now, Nuclear Medicine Society as well as the Radiology Society. So with this brief introduction, I want to invite Dr. Anuj for this panel discussion. So yeah, first I would like Dr. Arun to give some brief introduction why this is required and how it is very useful for your day-to-day practice.
Yeah. Thank you, Dr. Krishna, for giving me this opportunity. And for any, as a surgeon, I'm bothered about the stage in which they present. So commonly, as surgeons, we do surgery up to stage 3A. So we don't do surgery beyond 3A. 3B and all, they're absolutely contraindicated for surgery. So for routinely for staging, we ask for CT scan, CT, PET CT, MRI, and MRI brain and MRI chest sometimes. And these are all the investigation we ask for. So for mediastinal staging, for so the different modalities. Can I have the PowerPoint presentation, please?
Like everybody knows that lung cancer is the most leading cause of the cancer death. So I'll not go in details as we already wasted the time. So I'll just quickly move on the slides, further slide. Can you move on to the next slide, please, Ranjit, if you are holding? Yeah, so this is just to set, this was the 8th AGNM classification. As we already know, the tumor less than 3 centimeters comes into T1 and 3 to 5 centimeters in T2 and 5 to 7 T3 and more than 7 is T4. With invasion, depending on the invasion, smaller size can also go up to the higher T grades, and similarly N1, N2, N3. So let's not go into these details because anyway 9th classification has come. Next slide, please. Yeah, this is just to divide like how we decide after T1, N and M, how we decide about the stage 1, 2, 3 and 4. As sir already mentioned that up to stage 3A we can consider surgery. More than that, surgery is not an option. So now next slide, please. So grossly in the 9th classification, what they have changed is they have introduced, earlier it was only N2 nodal stage, now it is N2A and N2B. And similarly, like earlier it was only M1C, like when the metastasis, multiple metastasis to an extrathoracic organ, it was M1C. Now they have divided into M1C and M1C2, which means if the metastasis is confined to one organ, that is M1C1, and if metastasis is to multiple organs, that is M1C2. So M1C1 and C12 again doesn't have much implication in surgical management. It's just targeted and chemo management. But N2A and N2B classification has further downstaged many cancers that we'll see how it is in the further slides. Next slide, please. Yes, sir. So this is the first case. Is around 65-year-old male. He had come for some non-specific symptoms on weight loss or so. Slides have gone, I believe. Ranjit, this is Arun sir's presentation again. So sir, you just saw the image. So what happened, this patient had come with non-specific symptoms, and once we did the scan, there was a lesion in the left upper lobe, as you just saw, with the emphysematous background, emphysematous changes. Okay, now after this image, sir, I will ask you like what would be the options next? Would you like us to do a CT guide biopsy here, or can we directly go for the lobectomy? What would be the options, sir? Then I'll go further. What you say, sir? You are muted. You have to.
Yeah,
sir, you are.
Dr. Anuj. Yeah, Dr. Anuj. I'm audible now. Yes. So probably the lesion must be more than a centimeter, right? The lesion in the left upper lobe.
1.2 centimeter in the maximum.
So if the next thing is we need to do things before we do anything. First, we need to get the stage of the disease and diagnosis and staging. First, the diagnosis. So for the diagnosis, probably if CT guided biopsy, is it possible for you guys to get a CT guided biopsy? Because you said it is emphysematous lung and all, the chances of pneumothorax and all will be more. So explain to the patients, the chance of pneumothorax and putting a pigtail catheter and all those things. Probably you guys do a CT guided biopsy, right?
Okay. Yeah.
That's an option. That's one of the options. Yeah, that's one of the option. And on PET, the next thing is the PET CT is lightening up. What is the avidity there? SUV max?
SUV was around 3.5 or something, but looking at the lesion characteristics, speculations, background of emphysema, high likelihood of malignancy, sir.
Yeah. So SUV anything more, probably SUV anything more than 2.5 is suspicious of malignancy, right?
Malignancy, correct, sir.
Yeah. So this could be malignancy. If you can get a biopsy of it, that would be great. And the second thing is you need to stage the disease.
Correct.
The staging.
Correct. Yeah, I'll come on that. So, like, sir, there are certain papers which say if PET scan is positive on a suspicious lung lesion, we can directly go ahead with the surgery. Do we do that in regular practice, and how it is?
Yeah. So based on this, if you guys cannot get, if it is not possible to get a CT CAT biopsy, I would go and do directly the surgery.
Okay.
Surgery is one of the.
Okay.
The surgery would. Yeah. Ideally, it is the standard of care for any surgery is lobectomy, and nowadays we are also doing segmentectomy also. Segmentectomy, wherein we remove that part of the segment, and lung sparing. We want to spare as much lung as possible. You said it is emphysematous lung and all. So segmentectomy would be a good option.
Fair enough, sir. Fine.
And before that, I'd like to get a pulmonary function test also done.
Correct. Do you use this lung perfusion scan also, sir, to see which lung and which part of lung has how much perfusion to quantify the?
No, generally we don't get VQ. You're talking about VQ scan, right?
Yes, sir. Lung perfusion.
Yeah, generally we don't get that VQ scan, and if there's poor functions, if the PFTs are poor and all, we would order for VQ scans and all.
Okay, fair enough, sir. Ranjit, can you just put the slides back?
Did you guys get a biopsy of it, or?
Yes, sir. So the next slide was like PET CT, whole PET CT images were there. So there were no concerning nodes suggesting of any nodal involvement. And further, like PET CT being a whole body scan, you keep on seeing something here and there. So he had some well-defined lesions in the parotid glands, which were definitely unrelated. In old age, you do get parotid Warthin's tumor sort of thing. It's not uncommon. So, which normally I suggest not to, further evaluate. We can, because characteristic based on well-defined lesions and all, we can just leave them. At the max, ultrasound can be evaluated. So that.
What about the mediastinal? Are there any mediastinal lymph nodes?
No, sir. That's what I'm saying. No hilar, no concerning nodes, which was lighting up, which was the lesion. So this was one of the T1B N0 M0 sort of case. Okay. Now I'll move on to second case. Ranjit.
Accept with you. Yes. Early stage cancers, identifying early stage cancers is very difficult in India.
Because no such. Even if we see some lung nodule and we ask for follow-up, the patient doesn't turn up for follow-up.
Absolutely. Yes, correct.
Yes, sir. So, okay. Now this is the case 2, which is not much interesting as per the surgery, but I just wanted to show the variation in the lung behavior of the lung cancer. So this was a case who actually presented with metastatic disease. Can you? This is the primary lesion. I'll show you this is if you will see, it's the same patient, sir. Is actually presented with low backache, and X-ray spine showed a sclerotic lesion. And we directly moved the patient from there to, after seeing that sclerotic lesion, we asked the PET CT scan. When we did the PET CT scan, we found that lesion which I showed you on the previous slide. And then you can see there is a hemorrhagic brain lesion and quite a few other skeletal sclerotic lesions and a bulky left hilar N1 node. So this was just to show how the lung cancer can behave such an erratic way, that with a T1 lesion, T1A, there is a T1 N1 and M1C kind of disease. So directly fourth stage of disease. So let's move on the next slide. Then we can, next slide, Ranjit, please. Yeah, so as per the 9 AJC classification, it will come into 1C2. Anyways, leave that case. Now the case 3, she's a young female. Young means around 40 to 50 years of this thing. She had this opacity on chest X-ray, 6 months back X-ray, and nothing was evaluated further. She was kept on follow-up. Then finally, after 6 months of that first X-ray, she ended up with the PET CT. Then this is the primary lesion, sir. As the maximum dimension is around 3, little more than 3 centimeter. So it will fall into T2A. And next slide, please. This was the CT images. Now this is the PET CT images, sir. As you see, the primary lesion is lighting up. The SUV is more than 5 or so. So we are very sure about this malignancy of this. What happened is, in this case, is there is no N1 significant node, sir, but there is some right upper paratracheal, like 2R nodes are there. Now, like, looks little funny that there is no N1 node and directly N2 node, but it's possible. But that was the finding, sir. Now, how will we go about, sir? Like, do we offer a surgery? Do we do a EBUS or media stenoscope?
No. Yeah, as I said before, first we need a biopsy of that lesion where we want to confirm it whether it is. So as PET CT, it is lightening up on PET CT, so it must be cancer only. We need to get a diagnosis of it. Most probably, young lady, adenocarcinoma.
Yes, sir. Carcinoma only. Yeah.
Yeah. So there's some. I can see some of the lymph nodes in the paratracheal region. 4R.
2R.
Right paratracheal.
Upper paratracheal.
Yeah, upper 2R. So for that, we need to stage the mediastinum also. To stage the mediastinum, there are different ways of staging the mediastinum. One is EBUS, endobronchial ultrasound, and EUS, endo ultrasound. And then as surgeons, we do some what is called as cervical mediastinoscopy. That is now absolute. No one is doing mediastinoscopy. As a surgeon, I'm trained to do mediastinum. There are two types of mediastinoscopies: cervical mediastinoscopy and anterior mediastinoscopy. For that's known as Chamberlain's procedure. We do it for level 5 and 6 on the left side. So here, probably I would go with EBUS.
Okay, fair enough, sir. So I'm not sure what they did, but finally the patient was operated. Right middle lobectomy was done, and funny, or say, I would say, luckily patient, this lymph nodes found to be negative. So the final diagnosis was, can you move to the next slide, please? So I gave it as T2A and 2A, means I would put it, but final histopathological diagnosis was T2A and 0 M0. These nodes turned out to be negative.
So do you mean to say those are non-specific inflamed nodes?
Probably, sir. Probably. There was no tumor tissue found on the biopsy on those nodes.
Yeah. Sure. Yeah. Interesting.
Yes, sir. Next slide, please. So discussion. Next slide, please. Yeah. So this is another case, sir. Again, 55, 60-year-old male patient. Presented with some cough, and also, so you can see there is a large mouth lesion infiltrating right main bronchus. Approximate dimension is maximum is around 3.5 to 4 centimeter. Then he has N1 node, as you can see, right sided hilar node, interlobar nodes, hilar nodes, and right paratracheal nodes. Next slide. Yeah, this is the same patient's MIP image on the right side, and there is a right upper paratracheal node also, which is almost at the level of thoracic inlet. You can see here, sir. This is like, so basically T2 lesion along with that N1 and 2 nodes, as well as now this right paratracheal nodes, it becomes very difficult at times to classify it. Is it a 2R or 1R? If I make it a 1R, it becomes N3, and it becomes 3B or so. And if I label it as a 2R, then obviously still it's an N2 disease and surgical option remains. So how do we take up these cases, sir? What is your...
So the lesion is in the right lower lobe, right?
Right. It was infiltrating. Yes. It was going into, like, it's a hilar lesion infiltrating the main bronchus, sir. As you can see, it's reaching almost up to the carina.
So we need to get a bronchoscopy. We want to see any intrabronchial extension of that lesion there.
Extension is definitely there, sir, even on these images. It's
so
going up
so it's going up to. So what about the pulmonary artery and pulmonary vein? Is it the tumor? Is it engulfing or infiltrating?
I don't remember off way, but yeah, some encasement is there, sir, not infiltration. In the lower middle image, you can see the right pulmonary artery and the lesion relation. It's quite closely abutting to each other.
So probably this comes under locally advanced lung cancer. Probably, I'd go with neoadjuvant chemo radiation and then downstage the disease and then take up for surgery.
Okay, fair enough, sir. So basically, the pulmonary artery encasement and all, is it a contraindication for, or do we go ahead
Absolutely.
with?
It's no, pulmonary artery encasement on it's absolutely contraindication for surgery. And
Okay,
if it is encased and all, we cannot take out the whole lesion, right? And it may turn catastrophe. So initial downstaging with neoadjuvant chemotherapy, and then reassess again, restage the disease after 4 cycles of chemo
okay,
radiation, and then if it is possible, if it is resectable, we can take out the lesion.
take out later. Okay. How often do
It
we
is
offer?
It's
Sir.
centrally it's centrally located. The lesion is centrally near the hilum and all.
Yes, sir. Yes, sir. So how often do we offer pneumonectomy, sir, or it's nowadays not an?
Yeah, pneumonectomies and all. Doing right pneumonectomy is dangerous, because right lung uh, contributes about 55% of the ventilation, and left lung contributes about 45%. So
Okay.
doing right pneumonectomy, we don't advise. Generally, we don't advise.
Okay.
And if needed, we need to do right pneumonectomy. And based on the pulmonary function test and those tests, the test for pulmonary function test, we get it done and then take the
Done.
opinion of pulmonologist, and then we don't want the patient to go on to the ventilator right after the surgery.
Correct, sir. Correct. Fine. Fair enough, sir. Fine. We'll move on to the next case. Ranjit, next slide, please. Another next one. Next, yeah. So this was again a 62-year-old female, sir, presented with chronic cough for 2-3 months or so. Chest X-rays turned out to be regularly, there was only pleural effusion. Being a retrocardiac lesion, it was not appreciated on the chest X-ray, on consecutive chest X-rays by senior radiologists also. But anyway, since the cough was not resolving, we ended up doing CT. So this is the CT images. You can see large mass lesion extending from hilum up to down up to the diaphragm sort of thing with some pleural effusion. Next slide. So these are the PET images, sir, of the same patient. Now, if you will see, there is one thing which PET is doing, that it's telling that the lesion is not going up to the diaphragm. It is only limited. You can see the enhancing and lightening up part. Rest all is obstructive pneumonitis, non-avid part. But you can see. So lesion is actually, it's kind of, it has from like T3 to T4 lesion, it has downstage to T2, this lesion. Yeah.
Okay.
And other than that, obviously it has showed some lymph nodes. It's a subcarinal. Next slide, please, Ranjit. Yeah, if you see here, there is a large subcarinal which is N2 node, and obviously there was some N1 nodes also. But along
Okay.
with there is some effusion also. Now, like if there is a effusion in the same lung, do we consider it always it's involved pleural disease involvement and we turn it as M1A, or how do we take it, sir?
If there is I like to get a biopsy of that. First initially the pleural fluid analysis. I want to see whether any malignant cells are there in the pleural fluid or not, and then I want to know the pleural involvement. By doing some kind of wax thing to get a biopsy of the pleura.
Okay.
And I can see the subcarinal lymph node is lightening up, and so this could be this is cancer, or
Cancer, sir, definitely. It was proven cancer. Again,
biopsy
adeno-CA.
was done. It is adeno-CA. Okay.
Adeno-CA, sir. And because there was some FDG uptake in the effusion also, so I labeled it as M1A with T2. Just do the next slide, Ranjit. Yeah, so T2B and 2M1A. Back
Yeah,
again,
you
go
must
to
be.
the.
You are right. The pleural fluid. I need to get a pleural fluid analysis and to look for malignant cells, and I've needed biopsy of the pleura also.
Fair enough, sir. For now, I'll just like to, because this case finally it was went to a medical oncologist and it was treated as M1A disease, and they started some targeted therapy and all. But just
Sure.
as I was telling you, the lung cancer, how they behave weirdly, I would just like to bring your attention to, if you see the first image in the lower row, there is a small uptake in the myocardium, focal uptake in the LV myocardium, sir.
Yes.
I don't know if you're able to appreciate it or not, but like in first image, I ignored it. First scan, when I reported the first scan, I just, yes, sir, that one.
Yeah, I
I
can see that.
ignored it.
Yes.
Yeah, myocardium uptake can be normally present sometimes, so I just ignored it. and there is no classification which says myocardial metastatic involvement, how to stage it, sort of thing. It is still intrathoracic, but when the follow-up the patient came, it was not responding to chemotherapy. She developed renal mets also, but along with that, this myocardial lesion had become almost 3 centimeter mass. So,
interesting. So there's a
yeah,
mets in the myocardium.
Myocardial mets at the time of presentation. Yeah,
excellent.
just to show
good
the
case.
how cancer can behave.
Excellent.
Now, yeah, previous slide, Ranjit, please. Yes, sir. Now this is just one case again for discussion. This is a young male, sir, around 35-year-old, and has presented with some cough and all. Bronchoscopic finding was there is a lesion in the trachea posterior wall, small lesion, which is lighting up here, and the biopsy was squamous cell. And next slide. Along with that, there is another lesion in this lobar bronchus, sir. Along with the tracheal lesion, there was another lesion here.
Okay. So you mean to say there's a tracheal tumor?
Yes, along with it is an intrabronchial tumor here.
Yeah. So commonly, the biopsy which you got was squamous cell carcinoma or adenoid cystic carcinoma?
Squamous cell, sir.
Squamous. So generally, we see adenoid cystic carcinoma in the trachea.
Yes, sir. Yes, sir. We do see, but I think this case has some propensity or something, and it turned out to be this one. And he had multiple papillomas, sort of thing, also in the trachea, along with like two malignancies, 2 ulcerated lesions, and like other papillomas were not lightening up on the PET CT. The tracheal one lesion and this lesion in the bronchus.
Okay.
So, what are the treatment options for such cases, sir?
So probably chemoradiation. Surgery, we cannot offer surgery.
Even if it would have been only tracheal lesion, can we do some tracheal resection?
Tracheal resections can be done if it is confined. If I do a lot of tracheal surgeries also. If we can comfortably remove 2 tracheal rings.
Okay. Fair enough, sir. So if it's like localized tracheal lesion, we can offer surgery. Does it depend on histopathology or adenoid cystic? Does it depend on the histopathology or?
Yeah, squamous cell carcinoma. Generally, I came across adenoid cystic carcinoma in the trachea, wherein, commonly it is adenoid cystic carcinoma. And squamous, I'm wondering, you said squamous cell carcinoma. It might be one of the possibilities there.
Yeah. So, okay, if it is adenoid cystic and all and limited case, we can offer a tracheal
limited case, we can offer tracheal resection and anastomosis.
Fair enough, sir. Fine, sir. I think my cases are over. Next slide, Ranjit. I think this was the last case. Yeah, yes, sir. Maybe.
This was an excellent presentation. All the cases here, they're all interesting to watch. I mean, hear about the interesting, particularly the one you said about myocardium mets in the heart, myocardial mets, and interesting. Good.
Yes. Thank you, sir. Ranjit, you can share Arun sir's presentation.
So, as a surgeon, my topic is when to offer surgery for lung cancer patients. So this is I'm Arun Kanala. I've done my fellowship in the United States, and I'm currently working in Continental hospitals, and I'm doing freelancing in Hyderabad also. Many hospitals in Hyderabad. Next slide. And this is me in Harvard, 2011 to 13. Dr. David Sugarbaker was my mentor in the United States. He's the person in the middle is Dr. David Sugarbaker, second from the left. Next slide. And the top 5 cancers, in lung cancer comes in male, it is again third, and female also it's third. Top 5 cancers by gender wise. The next slide. And the classification, as you guys know, it's small cell carcinoma and non-small cell carcinoma. Small cell carcinoma will contribute about 15%, and the remaining common is non-small cell carcinoma. Again, in small cell carcinoma, they're all very aggressive tumors. Again, in next slide, non-small cell carcinoma, there are again 3 types of cancers. So adenocarcinoma, squamous cell carcinoma, large cell carcinoma. Next slide. Yeah, so small cell carcinoma, we don't offer surgery in small cell lung cancer. So it's only main chemotherapy only can be offered in small cell lung cancer. Next slide. And the latest classification TNM staging, as Dr. Anuj Jain discussed, it is 9th classification. It is in effect from January 2024. Next slide. And this is the thing which was already discussed by Dr. Anuj Jain. Next slide. And the different staging, the different staging, the different modalities of, the investigations which we offer in the CT, PET CT, brain MRI. Generally we offer brain MRI also, and invasive imaging, non-surgical, it is EUS, EVAS, and surgically I said 2 types: mediastinoscopy and Chamberlain's procedure, and VATS also. Next slide. And non-small cell carcinoma stage-wise, as Dr. Anuj Jain discussed, stage 1, stage 2, stage 3, and we offer surgery only up to stage 3A. Beyond that, we don't offer any surgery. It's only chemoradiation. Next slide. Yeah, the 5-year cancer survival rates are good. The pink one is females and the blue one is males, and you see the survival rates are good in females. And in smokers we see squamous cell carcinoma, and in non-smokers, generally in women, we see adenocarcinoma. Next slide. And next slide. These are all different stages already discussed by Dr. Anuj Jain. Next slide. Next slide. Stage 2. Next slide. Yeah, stage 3. Generally in India we come across a lot of the stage 3 lung cancer, wherein stage 3 is ipsilateral mediastinal lymph node involvement. So if the cancer is present in one lobe and the ipsilateral mediastinal lymph node is involved, it comes under stage 3. When if the contralateral mediastinal node is involved, it comes under stage 3B. So for that, no role of surgery; it's only chemoradiation and advanced immunotherapy, latest other modalities of treatment. Next slide. Stage 3. Next slide. Next slide. So stage 3 basically is locally advanced lung cancer, wherein the tumor will be present and some of the ipsilateral N2 nodes will be enlarged. What are the N2 nodes? The N2 nodes are from 1 to 9. They are known as N2 nodes, and from 10 to 14 are N1 nodes. Next slide. Stage 4A. Stage 4A and stage 4B is all metastatic disease. Then there is absolutely no role for surgery. It's only chemoradiation. Yeah, next slide. And the standard stage-wise treatment. As I said earlier, stage 1 and 2B purely surgical resection. Stage 2A and B again surgical resection. Stage 3A chemoradiation and surgical resection in selected patients. So the role of surgery comes up to stage 3A only. 3B and 4, it's all chemoradiation and chemotherapy, immunotherapy, and all the different latest modalities of treatment. Next slide. Yeah, so stage 3A, that's where we stop our surgery. Next slide. Next slide. Yeah, so generally before surgery, we get a pulmonary function test done. FEV1 is very important parameter for surgeons. If FEV1 is greater than 2 liters, they generally tolerate pneumonectomy. If the FEV1 is less than 2 liters, we get this VQ scans and all those things. So there's something called predictive post-operative FEV1. We calculate based on the case wise, and then proceed with the surgery. And we get the opinion from pulmonologists and anesthetists, everyone. And we will make sure that the patient will not go onto the ventilator after the surgery. Next slide. Next slide. So the main important thing is, next slide. So the different lung cancer surgeries, wedge resection, segment, taking out a small segment is known as segmental resection. Lobectomy, the 5 different lobectomies. On the right, there are 3 lobectomies. On the left, there are 2 lobectomies. And pneumonectomy is taking out the whole lung. Next slide. So all these things can be done by either open lobectomy, VATS lobectomy, and now in VATS also there is something called uniportal VATS, which we are doing it regularly, wherein through a single incision of about 3 centimeters, we go in and take out that lung cancer, and as well as the mediastinal lymph nodes as well. And the latest, the RATS is robotic assisted thoracoscopic surgery. This is coming up in a big way in India and in all other countries. Next slide. Yeah, the next slide, different surgeries, lobectomy, pneumonectomy, wedge resection, segmentectomy. The segmentectomy is generally done for patients with poor pulmonary functions. Next slide. Yeah, this is all, pictures, thoracotomy with, the big incisions are gone now. We are doing with only small surgeries known as VATS surgeries. Next slide. Yeah, this is how we place the port. Next slide. I'll quickly run through the slides. This is, VATS, wherein we put that's the picture which you see is called wound protector. We put that wound protector in the wound. We give about 3 centimeters incision, and then we put our camera and instrument scope and proceed with the surgery. Next slide. So this is VATS wedge resection. Wedge out that lesion. This is done commonly for secondaries in the lung. Next slide. Yeah, VATS. Next slide. So yeah, next slide. Main thing is I want to talk about the mediastinal staging. Mediastinal lymph node. So mediastinal lymph node surgery. Generally when we go ahead, we remove many of the lymph nodes in the mediastinum. Particularly on the right side, we take 2R, 4R, level 7, 8, 9. All the different lymph nodal stations we take out and send it for histopathology. On the left side, it is 5, 6, 2R, 2L, 4L, 5, 6, and 7, 9. These are all the lymph nodal stations which we take it on the left side. And we send it for histopathology. Next slide. Yeah, the different lymph nodal stations. N1, in the lymph nodal station, N1 and N2 nodes are there. N1 nodes are something from 10 to 14. And from 1 to 9, they are N2 nodes. Next slide. So this is how we do cervical mediastinoscopy, which we put our small scope inside and take out the lymph nodes in 4R, 4L, and level 7, subcarinal. Next slide. And this is all absolute. The pulmonologists are doing with E.B.B.S. This is a mediastinoscopy picture again inside. And the thing which you see are the lymph nodes in the 4L. Next slide. Next slide. Yeah, so overview, stage 1 surgery, stage 2 surgery, stage 3 concurrent chemoradiation, and consolidated immunotherapy. Next slide. Yeah, the survival rates already spoken by Dr. Anuj. Next slide. Yeah, thank you. Thank you very much.
So yeah, excellent presentation at Arun. So both together, you showed the staging and the treatment options which you offer for each. Like how the Indian scenario is, like at what stage you really get the cases. And
in India, it's hard. That's a good question. It's hard to get lesions in early stage cancer. Generally, we get either stage 4 or stage 3.
So stage 3 also still you can offer surgery, right? Stage 3 you can offer.
If it is there is isolated cancer and only there is node or bulky node, we don't offer. Bulky disease, bulky lymph nodes in the mediastinum, we don't offer. Only single mediastinal lymph node or 2 lymph nodes in the mediastinum. We do take out those.
Yeah. So yeah, having said that, do we have any screening techniques, like how to go about the screening the lung cancer, like then to pick up the early stage, like early that stage 1, 2, and early stage 3 disease, if you have to pick up, we should have some screening strategies to pick up this patient.
For lung, that's a good question again. For lung cancer, there's something called low dose CT done in some of the centers, and we do it in our Continental hospital. We do offer low dose CT scan screening for lung cancer patients, and there's some certain criteria for the patients to be selected for lung cancer screening. The patients more than 55 years and 20 pack years, more than 20 pack years. We do offer lung cancer low dose CT scan screening program in our hospital.
Yeah, how often we do it? Every year once or every year?
every year with more than patients with more than 20 pack years, and every year more than 50 or 55 years we do of lung cancer every year. They need to get low dose CT every year.
I think that the only thing I think which can save lives of the lung cancer patients. So that if you pick up it early, then if you offer the standard treatment like a resection and everything, then that's the only treatment which we can offer very well. Otherwise, in the advanced disease, I think the 5-year survival rate is extremely low. I think in lung cancer.
Absolutely, it's about 5-year survival rate falls as the stage advances.
Stage advances.
For stage 4, 5-year survival is 0. 1 5-year survival is 75. That is the difference.
Currently, the good thing is the good thing is after the introduction of VATS and all, VATS phlebotomist and all, survival rates are good, and the mortality and morbidity is very much less with VATS surgeries and robotic surgeries.
No. So Anuj, you have shown the PET CT, right? Usually we do CT for the staging of the lung cancers. We often use the CT, local staging also. How do you compare just CCT chest versus PET CT chest? Like how often you score better and all that?
Sir, the thing is, it's like very well defined, especially in the T staging is for N and M staging is with PET CT. Because now in India, we end up doing only PET CT sort of. Here we do our PET CT, we do as well as CCT chest. So while in Western world, CT test means contrast CT test only. CT would be non-contrast CT.
Right.
That's the difference. So here with the CT, we are trying to offer a complete stage. Well, that only you obviously need an MR. And now for brain obviously separately. That's how.
So that means at the time of diagnosis itself, we need to have the whole body of DG PET CT scan and MRI, CE/MRI of the brain, right? These two investigations.
For all cases, maybe T1, T2 sort of things. I don't separate.
But you have shown a case. But you have shown a lesion which is T1 lesion, but it has an extensive metastatic disease, right?
Correct, sir. But I think, like say, for example, if it's a small cell carcinoma, then MRI brain is named. We can. What do you say, sir? Arun? Sir, you are muted.
Unmute. You have to unmute. Yeah.
Yeah. Sorry. I can hear reason, but that's okay. You're talking about early stage cancer with metastasis and all, right?
Correct.
Yes.
Yeah, that's very rare. In the early stage cancers with meds, hardly we see that kind of thing. But there's possibilities there. That's the reason why we need to get PET CT and bone scans and all those things. Yes.
Fine, sir. It was
and
nice.
Very important thing is, how often you see adrenal meds in the lung cancer?
Frankly speaking, it's not very common, sir, but we do see. Like especially, I would say when when they are skeletal meds and all other knowledge.
Okay, fair enough.
Yeah, advanced disease, I think we see more of adrenal meds.
Yes.
And the other question is, how often you come across malignant mesothelioma, carcinoids in the lung?
Malignant mesothelioma is relatively rare only, sir.
But Dr. Arun's experience is different.
Yeah.
Do we offer
What
surgery
about
for mesothelioma?
Surgery for mesothelioma?
Yes, sir.
Yes, there are some surgeries for mesothelioma. They're known as radical pleurectomy and decortication, radical pleurectomy and decortication, and extrapleural pneumonectomy.
Okay, fair enough, sir. Yeah, carcinoids
So
are.
Go ahead, sorry.
Sorry. You were asking about carcinoids. So yes, again, not that common, but we do now. Since we do total scans, they do surgery. I would say in a year, maybe I will see 5 cases of carcinoids. Yeah.
Okay, thank you, Dr. Anuj, Dr. Arun, for an excellent discussion. Thank you for joining, Dr. Arun, from
Thank you very much.
giving us your invaluable time for us. Thank you, Dr. Anuj. Yeah, it's a nice discussion.
Thank you.
Thank you. We'll close the session now.